Upstate Medical University in Syracuse, New York invites you to be the informed patient with the podcast that features experts from Central New York's only academic medical center. I'm your host, Amber Smith. Today we're talking about cystic fibrosis with Dr. Christopher Fortner, the medical director of the Cystic Fibrosis program at Upstate. Welcome back to the Informed Patient, Dr. Fortner.
Thank you for inviting me back.
Now, the last time we spoke, you told us about a 3-drug combination called Trikafta that was freshly approved from the Food and Drug Administration. Now it's been in use for 5 or 6 years, so I'm anxious to hear how it's going. But first, you've lectured for Vertex Pharmaceuticals, which makes Trikafta. Today, though, you're speaking as a doctor who takes care of people with cystic fibrosis, right?
Yes, that's correct.
Now, before we get into how the drug works, can you give us a brief description of what cystic fibrosis is?
Sure. Cystic fibrosis, or CF, is a genetic disease that's inherited when a baby gets 2 mutated copies of a gene called CFTR, one copy from mom and one copy from dad. And without at least one working or not mutated copy of the CFTR gene, the body isn't able to let salt and water move properly in or out of the cells. That's especially important in cells that line many different parts of the body. It affects the airways, the pancreas, the intestines, the reproductive tract, even the sweat glands on the skin. And when the body can't regulate salt and water movement across the cell membranes, in CF, this results in thicker or more concentrated bodily fluids. On the inside of the body, these thicker secretions or mucus may block or obstruct different organs. It can block the release of digestive enzymes from the pancreas. It can block the intestines so that waste doesn't pass through properly, or it can block small airways or the sinuses with mucus that is difficult to clear out. On the outside of the body, it results in more concentrated or saltier sweat, and that can lead to dangerous dehydration or severe electrolyte losses.
How many or what % of babies are born with CF?
CF is a relatively common genetic disease, but the incidence will vary by ethnicity. It's most common in people of white European ancestry, where it affects about anywhere from 1 in 3,000 to 1 in 4,000 newborns of that ethnicity. It's less common in Hispanic populations, affecting about 1 in 10,000, and less common still in African Americans, affecting about 1 in 15,000. In people of Asian or Pacific Islander descent, it's much more rare. And the numbers are kind of all over the place for that group because it's very diverse depending on which Asian country they are originally from. But on average in the U.S., about 900 to 1,000 babies are born with CF each year across all the ethnicities.
Once they're born, how do you know, or what are the symptoms that come to life to tell you that they have CF?
Once they're born, most of them are picked up by what is called newborn screening. In the newborn nursery, a small blood sample is sent, and that is tested for various inherited or genetic conditions, and CF is one of them. In terms of symptoms, I mentioned the salty or concentrated sweat. That is a key factor in confirming the diagnosis. Measuring the saltiness of the sweat can confirm whether someone has CF or not. But common symptoms in CF can include difficulty with digestion, such as bloating, cramping, or difficulty breaking down the fats in the food. And if you can't break down the fats properly, that results in oily, bulky, or rancid bowel movements. Many people with CF have a chronic cough because of the thicker airway mucus, and that mucus also has more bacteria growing in it. And even though the salty sweat is a factor in CF, most people don't actually feel that as a symptom, but they do have to be careful to replace their salt and water losses. Otherwise, they risk severe dehydration.
How does cystic fibrosis impact a person's life?
I'd have to say that each person with CF may have a different experience. There's no one area of impact. Many have digestive problems as infants because of the pancreas being blocked and damaged before they were born. Some have severe intestinal problems with blockages that may require surgery as a newborn. Some people with CF have no digestive problems, but they still have difficulty with recurring lung infections or sinus infections. Others still may not have obvious lung or sinus problems until later in childhood or after they've started catching colds or respiratory infections. And some people with CF may not have any obvious symptoms until they're adults and are trying to have children. People with CF do have some fertility problems, and that may be the first reason that somebody decides to check a sweat test to see if somebody has CF.
There's genetics involved in causing this. What is the CFTR mutation?
So this might be a longer answer since I don't know how much cell biology I need to review for the audience, but I'm going to try to hit the highlights, even though we could probably talk about this for days and not run out of interesting details. There are many books written on this subject if people want to learn more. But CFTR is the abbreviation for cystic fibrosis transmembrane regulator. It's a long name, but it does kind of describe what the protein does. It's the name of the protein that doesn't work properly in CF. So normally, the CFTR protein forms into a microscopic tube-shaped structure, and that structure gets inserted into the cell membrane and regulates the flow of chloride across that membrane. The flow of chloride also results in sodium and water moving across the membrane, which is how CFTR regulates salt and water movement in the body. CFTR, if written in italics, is also the name of the gene that provides the instructions for cells on how to make the CFTR protein. So that's where it gets a tiny bit confusing when we're just talking out loud versus seeing it on a page. But mutations in a gene are like having a typo or a missing part of the instructions on how to make a protein. There are many different mutations that can affect the CFTR gene and cause CF. Right now, like as of today, we know of over 2,000, but more continue to be discovered. The mutations get sorted into different classes depending on how they affect the CFTR protein. Some mutations result in no protein being produced at all. Others result in a protein string that doesn't fold properly into a tube-like shape, and so the cell can't use it. A third class of mutations makes a tube that isn't open most of the time, so it doesn't let enough chloride, salt, or water move across the cell membranes. Still, other classes of mutations may result in a tube that is open, but doesn't let the chloride move through it fast enough, almost as if it was too small of a tube or the opening just wasn't big enough to let it do its job. And yet another class of mutations result in normal-shaped tubes, but not nearly enough of them, sort of a reduced number of CFTR proteins.
So the delta F508 mutation, is that similar to CFTR?
So that is a mutation within CFTR. Delta F508 or F508del, it's the most common CFTR mutation that causes cystic fibrosis. And we know a lot about it. It was actually the first mutation in the CFTR gene that was discovered. And when that mutation is present, the string of amino acids that is supposed to become folded into the full CFTR protein, it's missing a single amino acid to number 508. And without that phenylalanine amino acid, which is abbreviated F, that's where the rest of the name comes from, the string doesn't fold into a properly shaped protein. Now, most of the time, that improperly folded protein doesn't even get inserted into the cell membrane. Cells have mechanisms to sort of check for protein folding errors, and the cell won't try to use or insert a protein that didn't fold correctly. Even if the misfolded protein with F508del gets inserted, it doesn't make an open or effective tube for chloride to cross across the membrane.
This is Upstate's The Informed Patient Podcast. I'm your host, Amber Smith. I'm talking with Dr. Christopher Fortner, the medical director of the Cystic Fibrosis program at Upstate. Now let me ask you about Trikafta. How is it designed to work?
Trikafta is a combination of 3 small chemical molecules that get inside the cells and work together to help the CFTR protein fold into its tiny tube shape and get sent to the cell membrane where it can do its job. Those 3 ingredients are called elexacaftor, tezacaftor, and ivacaftor. And the first 2, elexacaftor and tezacaftor, they were originally described as correctors. They help the CFTR protein fold more correctly, even if there are mutations like F508del that affect normal folding. The third ingredient, ivacaftor, is known as a potentiator. It helps keep the tube open so that chloride can go through it, allowing salt and water to flow across the cell membranes. And even though Trikafta was primarily developed to address the CFTR mutation F508del or delta F508. It's also been found to help patients with many other CFTR mutations. The list of CFTR mutations that Trikafta is approved to treat has been expanded over the years, but it still doesn't help everyone with CF.
Why is it 3 pills?
The main reason that Trikafta is provided as 3 pills is for dosing flexibility. Sometimes people need to take a reduced dose because of other medications they may be on, or because their body may not metabolize or clear the Trikafta as quickly as someone else might.
So the first 2 morning pills, what do they do?
The 2 morning pills, those are the orange-colored ones, they contain all 3 of the ingredients that help the protein fold better, reach the membrane, and let chloride flow through it.
And then the evening pill, what is its job?
The evening pill is blue, and it only contains ivacaftor. And remember that ivacaftor is one of the 3 ingredients in the morning pills too. Ivacaftor has a shorter half-life in the body, so it has to be taken twice a day or it wears off before the next morning's dose.
How have your patients tolerated Trikafta?
Most people who have CF and can benefit from Trikafta, they've also tolerated it quite well.
Are there side effects?
Of course, there's a full list of possible side effects in the package insert or prescribing information, and the FDA requires Vertex to keep that list updated. Most of the side effects that we've seen in children have been limited or they resolve over time. Probably the most common we see in pediatrics happens usually a week and a half to 2 weeks after starting the medication. Patients may develop a rash, and the rash usually resolves without needing to change or stop the Trikafta. One potential side effect that we watch for carefully is the possibility of liver intolerance. Some children show increased liver enzyme levels on blood tests after starting Trikafta. And if those levels are too high, we have to stop Trikafta and watch for the liver to recover. That same situation applies to adults also. They are monitored very closely for liver tolerance of the medication when they start it.
It's only been 5 or 6 years. Is that too early to know if this drug is going to extend lifespans in general?
Actually, no, I think it's pretty clear that Trikafta is helping people with CF live longer. That even if we don't look at complex prediction models and equations for predicting how long people with CF are going to live, we can look at things like the number of people with CF who are over 50 years old. And that number's been steadily going up over the years, but before 2019, when Trikafta was first approved, it was only going up about 400 to 500 people every 5 years. In the 5 years since Trikafta, there have been over 1,000 more people with CF living past age 50. So the rate of people living longer is already proven to have gone up, almost double. Not only are people with CF living longer, but the number of people with CF who died each year, it fell to half what it was before Trikafta. So they're definitely living longer.
Well, let's talk about what doctors have learned about Trikafta since it's been in wide use. Did you expect to see a 3-fold increase in the number of women with CF who were able to have children?
So the truth is, being in pediatrics, I honestly hadn't thought too much about women with CF getting pregnant. Our colleagues who take care of adults probably thought about it much more often. When young women, teenagers with CF turn 18 or move on to try to start a family of their own, they shift their care over to the adult CF program. But it was a pleasant surprise to see more women with CF be able to have children after they started Trikafta.
So how has the drug made this possible for more women to have babies?
I think there's probably more than one way that Trikafta has helped women with CF have children. The reproductive tract is one of the organs that's affected by the thicker secretions of CF. So Trikafta may have directly helped make the cervical mucus thinner and therefore make it easier for sperm to reach and fertilize an egg. But I think perhaps even more important is the overall improvement in health for women with CF. Many women with low lung function due to CF were not even considering pregnancy as a safe option for themselves because as a woman's abdomen grows to make space for the growing fetus during pregnancy, that pushes up on the diaphragm and leaves less space for the lungs. So low lung function gets even lower as pregnancy progresses. The other challenge is if a woman with CF is pregnant and develops a lung infection, the antibiotics that can be used safely are limited to those that are known to be safe in pregnancy. And some of those may not be effective for the bacteria in CF. We know that two of the benefits for Trikafta are improved lung function and decreased frequency of lung infections. So with that, I think that may have given more women with CF the confidence that they could safely get through a pregnancy and help them decide to pursue pregnancy.
How has Trikafta affected the babies born to these moms?
That's a great question, and it's an area of active discovery. Most of these babies born to moms with CF do not have CF themselves. Yes, they inherit one CFTR mutation from mom, but if dad doesn't carry any CFTR mutations, the baby's only going to be a CF carrier. They'll have a good copy from dad and a mutation from mom. There's a study that our adult center is part of called the Mayflower study. It's an acronym that stands for something clever that I don't remember right now. But that study is collecting information about these babies born to mothers with CF who are on Trikafta or other CFTR modulators like it. And they're looking at lots of details like gestational age at birth and birth weight, incidence of any birth complications or congenital problems, or lab abnormalities like liver function in these babies. I expect the full results from the Mayflower study are probably going to be published in the next year or so. From what I know from the earlier reports, they have not seen any obvious problems or abnormalities that occur more frequently in babies who were exposed to Trikafta compared to children born to moms who were not taking Trikafta.
What else have you and your colleagues seen in people that are taking Trikafta?
I actually want to go back because there's another thing that was interesting in babies born to these moms. I talked about the ones who are carriers, but things got even more interesting after the first mom on Trikafta had a baby who also has CF. In that baby's case, dad is a CF carrier, and he passed on a copy of CFTR that had a mutation. What was interesting is that despite having two CF-causing mutations, the baby had a, quote, normal newborn screen. And that's because the newborn screen relies on a first step that checks for signs of pancreatic injury. And because this baby had been exposed to Trikafta throughout her gestation, she never experienced any significant blockage or injury to the pancreas before she was born. If we hadn't asked the state to please check for CFTR mutations, we wouldn't have learned that she actually has two of the F508del mutations. And we reported this as a case report from our center, and that helped the worldwide CF community learn what to watch for if women who are on Trikafta give birth to a baby who has CF. It may not show up using the normal screening processes. But in terms of what else we've learned, the main things we've seen is we see evidence of Trikafta either preventing or reversing common problems of CF. Some children who had pancreas problems at birth got better after being on Trikafta. For example, some of them needed to take by mouth an extra digestive enzyme as a newborn to help break down the fats in breast milk, formula, and baby foods. But after being on Trikafta for some months, their pancreas was able to start releasing enough of its own digestive enzymes that they could eat and drink without needing to take those extra digestive enzymes before they eat. There's also been a really interesting development after our case report of the baby whose mom was on Trikafta was published. Another mom who was not on Trikafta had read that report, and she learned through amniocentesis that her baby had two F508del mutations. There was also concern for that baby that there was possible intestinal blockage on a prenatal ultrasound. And this mom was able to work with her doctors and start Trikafta several weeks before the baby was born. And not only did the concern for intestinal blockage resolve by the time the baby was born, that baby also had some preserved pancreatic function. So it's not yet standard of care for pregnant moms carrying a baby with CF to start Trikafta. It is becoming more and more common once women learn they're carrying an unborn baby with two CFTR mutations. They're trying to work with their doctors to start Trikafta. That's fairly off-label use. Trikafta wasn't even originally studied in pregnant women. Most drugs are not studied in pregnant women. But like I said, through the Mayflower study and through continuing to pay attention and learn, we continue to learn how best to take care of these infants and try to prevent the organ damage from CF before it occurs.
It sounds revolutionary.
It's been incredible to watch. That first case report is almost 5 years old now. And to look at her medically, you would not guess that she's got CF because she still doesn't have any pancreas problems. She gets cold like any kid, but she really is living a life that is not much like CF. It's more like just being a preschooler.
You're listening to Upstate's The Informed Patient podcast. I'm your host, Amber Smith. I'm talking with Dr. Christopher Fortner, the medical director of the Cystic Fibrosis program at Upstate. So are you seeing in your patients that Trikafta is improving their lives?
Absolutely. From what I see as their doctor and also somebody who knows what the course of CF looks like without Trikafta, the best way I can summarize it is that with Trikafta, their body and cells act more like somebody who does not have CF. They're able to move salt and water where it needs to go in the body so that their secretions are not as thick, their sweat is not as salty. They're really much, much healthier.
Does it reduce the need to clear chest mucus?
Usually, if the lungs or pancreas were damaged before a person with CF could start Trikafta, for example, if they were older by the time Trikafta was approved, those organs may not heal completely, but they still tend to improve. Many people who had a daily productive cough before Trikafta report that their cough either dried up or resolved completely. About a year after Trikafta was approved, the CF Foundation sponsored a study known as Simplify that tracked what happened if someone on Trikafta stopped using one of the inhaled medications that they used to use every day to make it easier to clear mucus from their lungs. Our center was also part of that study, and the results were really encouraging. Over a 6-week period of not using nebulized Dornase, which is one medication, or hypertonic saline, which is another, people with CF who were on Trikafta did not experience an increase in cough, nor did they have a drop in lung function. Now, prior to Trikafta, those people used those medications once or twice a day, every day, to help clear the mucus from their lungs. And after the Simplify results were reported, many people changed from daily use of those therapies to only using them when they had a cough.
What about with the digestive symptoms? Is it helping with that too?
It seems like it does. Many people with CF struggled to gain weight in the past before Trikafta. And whether it's from symptom improvement or other causes, now we're seeing patients who can grow and gain weight more effectively without needing to take appetite stimulants or calorie supplements, or in some cases, they even needed overnight tube feeds to maintain a healthy weight. Much like the lung symptoms, we're seeing people with CF be able to stop some of the therapies other than Trikafta and still remain really healthy and keep a good, healthy weight.
Do I understand correctly, Trikafta has been approved now for kids as young as 2?
Yes, as of April of 2023.
Is it liquid or pills, or how do kids that young take this?
But kind of an interesting formulation. It comes as little sealed packets of little granules. The granules are about as big around as a grain of rice, but they're shorter. And they can be sprinkled on a food that the child likes. I'm also told that they dissolve pretty quickly in milk or yogurt. The granules themselves don't have a specific flavor, like they're not strawberry or chocolate, but they do contain an ingredient to sweeten them. And like the pills for older kids or adults, they're divided into a morning packet with all 3 ingredients and an evening packet with the ivacaftor only.
The children who start taking this at age 2, will they have to take it forever?
I'm going to say maybe. Forever is a really long time. I would definitely say they will be taking it until something better comes along, because we know that if people with CF stop taking Trikafta for whatever reasons, their cells will go back to having trouble regulating salt and water movement, and the symptoms of CF are going to return.
Is there progress toward other treatments for CF? Because the Trikafta is for the people with CF who have the Delta F508 mutation, which is the vast majority, but it's not all. Are there treatments being worked on for the other people with CF?
Absolutely. This is what the CF scientific community is really focusing on now, how to help people with CF who either aren't eligible for or can't take a CFTR modulator like Trikafta. There are companies other than Vertex who are developing CFTR modulators that may help mutations other than F508del. And researchers have also been testing Trikafta to find other CFTR mutations that were improve in response to it. The list of approved Trikafta responsive CFTR mutations continues to grow, and was most recently expanded in December of 2024. Beyond the modulators, the CF Foundation has also invested millions of research dollars into strategies for gene therapy, either by giving an unmutated copy of the CFTR instructions to the cells or trying to correct a mutation so the cells can make enough properly folded CFTR to do its job. And many of those studies are in the early phases, so we're probably years from seeing them as approved treatments. But the same was said about Trikafta 7 years ago. They were in early stages and trying to move forward. There's also a push to find more effective strategies to treat some of the challenging lung infections in CF that continue to be a problem even with Trikafta. So Trikafta has been a huge help for many people with CF. I think it should truly be recognized as a game changer. And as we look back over the past 5 years, every trend in CF has gotten better when people could take Trikafta. Some people who could start it early may never develop clinical features of CF, but like I said in response to your previous question, if something better comes along, people with CF may not need to take Trikafta forever. The CF community continues to look for whatever that something better may be. And I don't see any signs of that search stopping until there's a cure for every person with CF.
That's good to know. This has been very informative, Dr. Fortner. Thank you for your time.
My pleasure. Thanks for having me back.
My guest has been Medical Director of the Cystic Fibrosis Program at Upstate, Dr. Christopher Fortner. The Informed Patient is a podcast covering health, science, and medicine, brought to you by Upstate Medical University in Syracuse, New York, and produced by Jim Howe, with sound engineering by Bill Brokel and graphic design by Dan Cameron. Find our archive of previous episodes at upstate.edu/informed. If you enjoyed this episode, please invite a friend to listen. You can also rate and review the Informed Patient podcast on Spotify, Apple Podcasts, YouTube, or wherever you tune in. This is your host, Amber Smith, thanking you for listening.